Hello, everybody, and welcome to the Hughes Clues Final Exam Review. A lot of information in this course. I know that's like, duh, yeah, there has been. And so, therefore, I'm going to divide this final exam review recordings into four sections 1A, 1B, 2A, and 2B. And again, because there is so much to learn, I'm really only going to hit the highlights, the things that I think are important concepts for you to grasp. I think you've done a lot of information in the Senior 1 semester, and if you add that to what your knowledge was on J1 and J2, I think you're going to do fine on ATI. There's a lot of students that tell me that the ATI in the senior semester made more sense to them because they felt like they really had all the information or the majority of the information at their fingertips, and the rest of the information they could kind of wing it. So ATI in general is about test taking. It's not as much about content as it is about test taking strategies. So that's how the NCLEX practice questions help you, because they're more about strategy, or what I call the trickery of nursing exams. Be sure and follow your course rules for ATI preparation, and then know that all of this information should help you on NCLEX, which is your final end result, and where you can, once you pass NCLEX, then you can show you the money. All right, one of the things you have to do for the final exam review is not only listen to this recording, but also to do or look at what I call the final exam review key docs or key documents. And so what this does is there's so many places in the Canvas module where there's information and add-on documents. It's just ridiculous, all the places you have to go. Likely you've printed all of them up, but what I'm talking about is you have to look at that supplemental information. That would be the information about pacemakers, airway management, blood administration, hemodynamics, chest tubes, and very importantly, sexual intimacy after MI. So these are the things you need to look at. Are there a lot of questions on each of these topics? No, there's about 2 questions, but if you consider that's about 7 topics or so, that's 14 questions. That's a lot of points. Now, as I talk, I know that some of you might go, oh my God, the final, this is just horrible, and I've got to do well on it to keep my grade or improve my grade. So I'm going to tell you that the final exam is, in my opinion, very fair. Dr. Reed really does work hard to test you on the big concepts, the key concepts, and not the little nitpicky stuff that you had to have on exam 1, 2, and 3 because there wasn't as much material. So most students, in my experience, in all the semesters that I've been doing this, they really do fairly well on the exam, the final exam. A lot of times it's their best grade, and the good news about that is that it's worth so much more than the previous exam, so it really can boost your scores. So fret not, stay calm, you can do this. Now, you will have a hard time doing this if you don't study. You have to study. The other thing you have to look at, besides those key documents, is you have to look at all 3 of Dr. Reed's Jeopardy handouts. Dr. Reed does not lecture after exam 3. All the material's been delivered, and so if you're thinking, well, what is Dr. Reed going to test me on? Well, there's your clue. So look at exam Jeopardy or exam review, however it's termed in your semester. Look at exam 1, 2, and 3 review, and just kind of keep a note of some things that perhaps you don't remember that were addressed on exam 1, 2, and 3, because those are going to be fodder on the final exam. What to put on your exam sheet, because there's so much information. So what I say is what I repeated from Miss Arena, because she's the one that made the original suggestion, and that was look at your exam 1, 2, 3 exam review sheets. Hopefully you've kept them or kept a picture of them. And make sure that the things that you used on exam 1, 2, or 3, those are the things you need to put on your final exam. You've got limited real estate space on that sheet, so put the key things. And I would say to you that most of the items on your final exam are going to come from exam 2, because you had all of that hemodynamic data, all of those medications, all of the shocks. There's so much stuff on exam 2 that you hopefully wrote down. So that's where I would go. So if you have questions about that, email me. I would also say make sure you divide the topics as best you can with either use a colored marker or some kind of different color ink kind of marking each of those items. Then the other thing I would recommend that you do is there is not enough time to do either read every lecture note of Dr. Reed's or do every Hughes Clues module again. There's just not enough hours in the day. And so what I suggest that you begin with is practice questions. Do every practice question that you have of mine, the one that I wrote. So that would be the Student Success Review Session practice questions, as well as if there's some available, do the Want to Excel exam practice questions. And then if you pretend that it's an exam and you just do them and you get it right, then keep going. If you miss the question, make sure you look at the rationale. If you read the rationale and you're like, I don't remember studying this information, then you're going to have to go back to the notes. So that's when you go back to the notes. Again, I haven't encompassed everything that you need to do on the final exam, but I've been told by many students that it does encompass a pretty good job of getting the key points. And so if you find in your semester that I did a lousy job on the final exam review, then let me know, and then I can make some changes for the next exam. I did not include a lot of the information from exam 3 because you just had it. I don't think I need to re-include it again. Practice, practice, practice questions, and then that will jog your memory of the content. Email me if you have questions. So let's start from way back in the beginning, from exam 1, and we talked about ABG, or you learned how to interpret ABGs. Now, I'm not going to belabor the obvious. I'm not going to go through how do you interpret an ABG. If you don't know at this point, then you need to go back and redo that module. Here are the tips for the ABG questions. What I have found is that students will try and configure the ABGs in a hurry because you're stressed. It's a timed test, and they mess it up because you get influenced by Dr. Reed's exam suggestions. So what I recommend is that you look at the ABG, then go to your scratch paper, configure the ABG, figure out what is wrong with the ABG, and then look back at what Dr. Reed is asking you about the ABG. You're either going to be asked about what's the fix for this ABG, what's the compensatory mechanism for this ABG, what's the treatment for the ABG, what diagnosis or what problem is causing this ABG. Those are the questions that you can expect to be asked. And it's to be easy to figure that out if you know what the heck the ABG is, if you've labeled it. Place the normal ABG values on your exam sheet. I can't tell you how many students go, oh, I forgot that value. Put it on there. Remember, or pay close attention and note that the PaO2 is equal to millimeters of mercury, so it's different than SaO2 and SpO2. That's oxygen saturation. They're percents. They're different. They're different from what they're listing, what information, not that you have to know that. It's the values that are different. And you have to note that, hey, this is a PaO2, and if you had an 80 millimeters of mercury as a PaO2, that's a good value. That's a normal value, and that's far different than the SaO2 or SpO2, the oxygen saturations. Put what I call the ABG grid. I'll show you the visual on that in just a minute. Put it on your exam sheet because, again, if you're going to have 80 questions or whatever it is in your semester and you're at question 73 and you get this really difficult ABG, your brain's going to go, I quit. And so make it easy on yourself and put these things on your note sheet. Now, this is one thing that I have noticed quite consistently in almost every semester is that students will identify that the ABG is some kind of respiratory problem. It could be a respiratory acidosis or a respiratory alkalosis. Either way, if it is a respiratory problem, if the first name or middle name, however you want to say it, of your ABG baby is a respiratory, whether it's acidosis or alkalosis, the fix is going to be something to do with the respiratory system. Breathe in a paper bag, or breathe in a plastic bag, or give oxygen, or breathe faster, breathe deeper, whatever. The fix for a respiratory problem is always going to be a respiratory intervention. Here's the ABG grid that I'm talking about. Where is this located? Well, this you can find in the ABG, in the Hughes Clues ABG worksheet. Just copy the whole grid on there, because that way you won't have to think. As you can see, it gives you the cause, what's the problem with each of the states, why, what's the intervention, what's the compensation, and so on. I think it's a lot easier to do it this way. You can disagree if you want. Now let's talk about compensated ABGs. As a reminder, compensated ABG means those ABG pHs that fall within the normal range. And then when there are other values that are abnormal, then that's when you know, okay, if there are values that are abnormal and the only thing that's normal is the pH, well, we know it's a compensated ABG, and you use this triangle. So let's do this ABG, and then let's talk about this ABG and specifically how it relates to the COPD patient. So we look at this pH, and as you have identified, this pH is 7.38. It's normal. It falls between 7.35 and 7.45. And when we look at it as a compensated ABG, we have to say, well, what side of the triangle is it on? And we see that it falls on the compensated acidosis side of the triangle. So it is, if there are other values that are abnormal, it's likely a compensated acidosis. And we see that this first item is the CO2, and it's abnormal. It's greater than 45. Therefore, yes, this is a compensated problem, compensated acidosis problem. We see that the CO2 is 55. Then we see that the bicarb is elevated. So if you get your arrows out and you've got a downward arrow for the pH and an upward arrow for the CO2, we can see that this is a compensated respiratory acidosis. When we look at the bicarbonate is up. That does not fall with metabolic equal. It is metabolic opposite, and therefore it is all about compensation. That metabolic system holding on to bicarbonate, making more bicarbonate to counteract or compensate for the elevated CO2 value. Then we look at the O2 and we see that the PaO2 is 63. That is not great. Quote unquote, normal is 80. And then we see that the O2 sat is 90%. Now for critical care, this is a acceptable oxygen saturation. This is an acceptable oxygen saturation value. In MedSurg, in ATI, in NCLEX, it's too low. You have to default back to those values. I know, annoying. Then we've got the PaO2, what was mentioned in the course. Let me go back. Oh, well, I'll show it to you in a minute. In our course, Dr. Reed in her notes has said as long as the O2 sat or the O2 PaO2 is somewhere above 60, then you can consider that the patient is doing okay. And with an oxygen saturation of 90%, all right, this patient's probably doing okay. So what does this profile fit, or who does this profile fit? Well, this fits the COPD patient. This is very, very typical for a COPD patient that is doing okay. Well, how do you then determine about a COPD patient that's not doing okay? What would you expect to see? It's all about that pH. If that pH was 7.32, anything less than normal, then that means something's wrong, especially also, and in addition to, if that PO2 is less than 60, the O2 sat was less than 90, now your COPD patient is in jeopardy. But as long as the pH falls in the normal range, as long as the PO2, according to Dr. Reed, is above 60, as long as the O2 saturation is at 90 or above, then this COPD patient is doing okay. Why? Because COPD patients hold on to CO2 on a good day. That's part of their disease process. If this does not make sense to you, then email me. What about signs and symptoms of respiratory distress? Well, I'm hoping again that by this point, at the end of your senior semester, you get it. You know what a respiratory failure or a distressed patient looks like. Why? Because that's the only way that Dr. Reed and ATI and NCLEX can get to you or can indicate to you that the patient's not doing well. If your patient has an PaO2 of, say, let's call it 65 or 70, and they look happy, their eyes are wide open and looking at you, and they're smiling, and they're not complaining of shortness of breath, that patient's doing okay. However, if that same values, if that patient's PaO2 was 70 and their eyes were droopy and they weren't responding to you, and you could see uses of accessory muscles, and you could hear wheezing, and the respiratory rate was 44 and their heart rate was 130, and maybe they look a little dusky, those are signs of respiratory distress. So the numbers are just numbers, and you have to look at the adjectives of the patient description to identify, what am I being told? What does this patient look like? Respiratory failure, by definition, is that which means the respiratory system not doing its job. It's not providing oxygenation very well, it's not getting rid of CO2, and it's not ensuring a normal pH. So that would be CO2 retention, hypoxemia, and an acidotic pH. That's when we know that this patient has respiratory failure. It could be one, it could be all three. So you just have to look at the descriptors. So what treatment would you anticipate? Well, if the oxygen status is low, you got to give oxygen. If the CO2 is elevated, well, you need them to breathe off CO2, so you're either going to have to stimulate them to breathe deeper, breathe faster, or you're going to have to bag them, or you're going to have to do something, kick those or flick that baby's feet, something. But you also could elevate the head of the bed, make them cough, make them deep breathe, give steroids, just all kinds of options. Well, what about non-invasive mechanical options? Well, the easiest one, or that the most common non-invasive mechanical option, is CPAP. Will you get a lot of questions on CPAP? No, you just need to know that it exists. It can be BiPAP, it can be CPAP. The bottom line is it's help with inspiration and or exhalation, and you would expect, if your patient is on some kind of CPAP, BiPAP, that their work of breathing is tolerable for them, and that they're able to maintain a normal pH, that they're able to remove CO2 and or oxygenate their body. So those are the things that you would look at. If those things aren't happening, if the patient's mental status is changing, becoming worse, if the oxygenation saturation is dropping, well then the CPAP, the non-invasive measure, is not helping. What about ventilation? Well, we know that in situations where the non-invasive maneuvers are not helping, or the turn, cough, and deep breathing is not helping, well, then it's time to assist or prepare the patient for intubation, and then the physician or CRNA will intubate the patient. Now, one thing about ventilators, what do they all have in common? And I say ventilators because they all provide positive pressure ventilation. Remember that PEEP falls in this same category. PEEP stands for positive end expiratory pressure. It's all positive pressure. So whether it's a ventilator or whether it's a ventilator with PEEP, what happens is there is decreased venous return. The cardiac output can go down, which will cause the blood pressure to perhaps go down. Does this happen in every patient? No. Each patient can tolerate it better than some others. You just have to be aware that it is a complication of PEEP. It is the disadvantages of positive pressure and or PEEP, and therefore you have to watch for it. Let's talk about ventilators again. Let's talk about ventilators modes. There's lots and lots of ventilator modes. What is a mode? It is how does the patient and the ventilator interact? Do we want the ventilator to do all the work? Do we want the patient to do most of the work? Do we want them to be equally responsible for the work? That's what the mode is all about. Now, you were presented with a few different modes. Probably the most common that you saw in the hospital of a mode was assist control. Assist control kind of allows the patient to breathe, but pretty much for the most part, the work of breathing is done by the ventilator. Again, unlikely that you will get a lot of specific questions related to tell me how assist control works. It's going to be more about, hey, your patient doesn't breathe at all. Which ventilator mode would you pick? And you know that assist control is going to be probably one of the most common ventilator modes that is utilized for patients who are not able to breathe well or at all. Now, Dr. Reed did present to you CMV, which is complete mandatory ventilation. That could be on the test. As far as you got to realize it's a mode that does all the work. It's not often seen in the hospital. Then we talk about another kind of mode that is opposite or different than assist control. SIMV is really about a weaning mode. Well, so why do we wean? Well, first thing, why do we put patients on the ventilator? Patients are put on the ventilator because they cannot manage their CO2 removal. They cannot take in enough oxygen. Their pH is abnormal. In other words, they have respiratory failure, one or all three of the respiratory failure components. But we know that we're going to put them on a ventilator, and then we're going to support them during their time of need, and then as soon as they get going and they're ready to breathe on their own, then bam, we need to wean them off the ventilator because we want to normalize the ABGs and get them off the ventilator. SIMV is such a thing. It is the weaning mode. And so with this weaning mode, there are other things that have to be helped. And we'll talk about that in a minute. So let's look and kind of do a whole thing. We'll do un-ABG so that we can see, because I've given you what I consider to be a Hughes clue, and that's if the problem is with the CO2 on your ABG, then the rate and or the tidal volume should be changed. Then as far as the oxygenation status of patients, then we want to ensure that the PO2 is greater than 60, although normal is 80 to 100, and that the SpO2 is greater than 90. If there is an oxygenation issue, then alter the PEEP or the FiO2. So, you know, this is a lot of stuff that's important. If you don't feel like you can remember it, put it down in your exam sheet. So let's look at this ABG for grins and see, what do we need to change? What do we need to fix? And we can see that with this pH, the pH is 7.50. That is an alkalotic patient. We look at the CO2. We see that the CO2 is down. The pH is up, the CO2 is down, bicarbonate is normal, and we see that the O2, PaO2 is in the normal range, but look at that oxygen saturation. It's 88%. So what kind of problem do we have? Well, we have an oxygenation problem, and as a counteract, we have a CO2 that is driving the pH into the alkalosis range. So if we look at this, we see that the rate is too high. And not only that, this is assist control. So this is a patient who we've got a problem with oxygenation. Too much CO2 is being taken off. We need to decrease the rate. And we see that the FiO2 is up at 100%, but the oxygen saturation is crummy. So what's the fix? We got a CO2, there's too little of it. We need to decrease the rate and or tidal volume. You're never going to be asked to pick one or the other. It could be either or. Then we see that the FiO2 at 100% is at the highest it can be, but the oxygen status of the patient is still lousy. We need to increase the PEEP so we can get that FiO2 down, because we know that when we give supplemental oxygen at high levels over a long period of time, that is dangerous for the patient, And even though it is at 100%, it's still, the patient is still not being oxygenated, and this is a crummy scenario. We've got to get that PEEP up. We need to increase the PEEP so that we can help with oxygenation. So let's look at some more settings. We talk about the SIMV as the weaning mode, and I apologize if I'm kind of zipping around because these are hopefully concepts that you remember, but we're talking about some settings with the SIMV. And we see that SIMV is a weaning mode. So what are some of the things that you want to look at with a weaning mode? What are some patient scenarios? Well, we know if our patients are ready to be weaned off because their ABGs have normalized, well, we need to get them off. So SIMV is the weaning mode. But we have to consider, well, what's the story? What is happening with this patient as far as drugs or medications? You do not want these patients to be strongly sedated. Why? Because if you're going to wean them, you want them to do the work of breathing, and they got to be awake to breathe. So watch your sedation amount. And then notice on this, we've got the SIMV is 10%, and we've got some, we want our patient to breathe because a rate of 10 is not very rapid. It's less than what we consider normal. So you want to watch your patient closely. If you turn the ventilator down to 10, is your patient picking up the slack? In other words, are they breathing on their own? And if they're not breathing on their own, what do they look like? Are they looking like they're restless? Are they shaking the side rails because they're in distress? Is their heart rate going up? Is their oxygen saturation going down? If you notice your patient when they're being weaned get into distress, that you should stop the weaning process and go back to the setting that they were on before all of the distress occurred. Let's talk about another thing, and that is PSV, pressure support ventilation. Whenever an individual is on an SIMV, that's the weaning mode, and we want them to breathe, we have them or the patient is at somewhat of a disadvantage, because if you look at this picture, you see that they have an endotracheal tube in, and that endotracheal tube is a straw. Try breathing through a straw and see how much work you have to do to breathe in. And then you see that you've got this long tubing that's attached to a circuit. So you're weaning the patient off the ventilator, you're making them do more of the work, but at the same time, you're asking them to do even more work because of the mechanics of the endotracheal tube and the tubing. So what pressure support ventilation is, pressure support ventilation is help or support on inspiration or inhalation. What that means is when the patient attempts to inhale, the ventilator will help push that breath in so that the patient doesn't have to suck as hard to get the air in. So what do you need to remember? Pressure support, as it's sometimes called, or pressure support ventilation, same term, is help on inhalation. And we can help the patient a little bit, give them a little push, or give the patient a big push as they inhale. And you don't have to know these numbers, but just so that you know that pressure support ventilation of 20, that's a lot of help, as opposed to pressure support ventilation or pressure support of 5 is just a little bit of help on inhalation. Now let's go to PEEP, positive end expiratory pressure. So what is this? This is help on exhalation. We've got the list or the list of PEEP advantages, or what's the good thing about PEEP, and the PEEP disadvantages, the harmful things that can occur. They don't always occur. They can occur with PEEP. You need to know these. See how the alveolar recruitment means we keep the alveoli open. That means the alveoli is available for gas exchange. We know what gas is it mostly involved with, and that's the O2. PEEP is all about O2. Improved gas exchange, decreased work of breathing, and it allows us to decrease the supplemental oxygen, because in our scenario that I just talked about, if the supplemental oxygen is at that can be damaging and harmful to the lung tissue itself. We got to get it down as fast as we can. I think Dr. Reed mentions in her notes somewhere that any patient who's on an FiO2 or supplemental oxygen that's greater than 50 or 55 is at risk for damage to the alveoli from that supplemental oxygen. Disadvantages, and they're all listed there. So let's talk about this in detail. Again, PEEP is positive end expiratory pressure. If you think of a balloon, PEEP helps keep the balloon open so that it doesn't collapse and have those sides kind of adhere together, just like a party balloon when you pull it all out. Decreased work on the next inhalation. There is increased time for oxygen to diffuse, and we can use less of the supplemental oxygen. Again, I've pointed it out here, our rules and goals. The goal is to ensure a PaO2 of 60 or better, even though we know that normal is 80 to 100, and we want the oxygen saturation, SA or SpO2, to be greater or equal to 90%. Disadvantages of PEEP. So there's a few of them. One of them was decreased venous return. Mentioned previously that decreased venous return can occur with either PEEP and just any ventilator. It doesn't always happen. Now, I do have the long version of my explanation of physiologically how is it that PEEP will cause a decreased venous return. I'm not going to go into that. Inquiring minds, pause the recording and read. Email me if you have questions. What everyone else or everyone really needs to know is that PEEP or any ventilator has the potential to reduce venous return. Therefore, the cardiac output can go down and the blood pressure can go down. That's one complication of PEEP or disadvantage of PEEP. What's the other? The other is barotrauma. Barotrauma means pressure trauma. In other words, if you have PEEP on your alveoli, or if you think of it as your party balloon and you put too much pressure on that party balloon, pop, it will go. And that's the same thing with the alveoli. The pop goes the alveoli. What happens with barotrauma? So here's your picture, your visualization, and we can see that this is, just a red mass, which is your lung, but think about those as a bunch of little grapes. And so you have all these grapes that are the alveoli. They're all party balloons. So you've got a mass of party balloons in this area. And as that PEEP, PEEP, PEEP increased pressure causes that party balloon to pop, as evidenced by this big gap here. Now, every time the patient breathes in and air goes through that air sac, out it goes into the pleural space. And so this can result in a pneumothorax, which can ultimately result in a tension pneumothorax. Let's get the details on that. So the first thing that it can cause, your barotrauma can cause, is that you can have diminished breath sounds. So that is what is your first clue for any kind of barotrauma / pneumothorax. You know your exam patient has a pneumothorax when you're told on the exam that there's unequal breath sounds. What does it mean to have subcutaneous emphysema? Well, if you look at this picture down on the bottom, you can see that with our pneumothorax and we have air in the pleural space, it's a physics thing. Some of that air can just kind of leak out from the pleural space and into the subcutaneous space, and you can have a subcutaneous space all along here that is just filled with air. And it will feel like Rice Krispies in a baggie, and so that is known as crepitus or subcutaneous emphysema or subcutaneous air. So these first two things, unequal breath sounds and or subcutaneous air or emphysema, when those two things are present or one of the other is present, then you know your exam patient has a pneumo, and that's always a bad thing. Now, if you have a ding-dong nurse that doesn't quite get that there's unequal breath sounds, because why am I supposed to use my stethoscope to hear things and they didn't, then this air can collect, and with all that air, it will begin to push the heart and trachea over to the opposite side. And that's when we know that we have a tension pneumo, when you see tracheal deviation. As the trachea is pushed and the heart is pushed, that pushing force squeezes the heart. It smushes the heart. And the heart cannot expand during diastole and fill. And therefore, you have a decreased ability to fill, decreased ability of blood to zoom through and out the heart, and therefore the cardiac output goes down and the blood pressure goes down until all of a sudden you have a patient with either asystole or PEA. Now we're going to talk about the ventilator alarms. There's two kinds of alarms, a high pressure alarm versus a low pressure alarm. Again, inquiring minds, you want to know all the details, stop the recording and read it. For the rest of us that feel like our heads are full enough, then note that the high pressure alarm means the lungs are either stiff, they're less compliant, that means less stretchy, or they're more resistant, that means they're stiff. They both mean the same. Notice more stiff versus less stretchy. Same thing. And that means that there is some disturbance or inability of the ventilator to push in air. There's some kind of occlusion or restriction or some kind of blockage. And so therefore, when the high pressure alarm goes off, the things that it could be are lots and lots of secretions like snot or mucus, and therefore the patient needs suction. If there's development of ARDS, if we have a more resistant and less compliant state, which is what occurs in ARDS, then it could be that which is causing the high pressure alarm to go off. The patient can bite the tube, there could be kinks in the tube, the patient can cough. All of these will cause the high pressure alarm to sound, and you can silence the alarm as you assess your patient, but you never, ever, ever turn off the alarm. I know, turn off the alarm, isn't that the thing? Is silence the alarm? Well, not really on an exam, because silence just means you've acknowledged that the alarm is going off, you're there to fix the problem, but you don't want to turn it off. You want it to be on. Now, that's obviously the low pressure alarm. If it keeps sounding, we know that that's opposite, that there is less resistance to flow. Your lungs are like a party balloon. There is always some resistance, and when for whatever reason there's no resistance, then the low pressure alarm will go off. So think that that is occurring because of a leak somewhere. The endotracheal tube or cuff balloon has bit the dust, and so it's not working anymore. The tubing is disconnected. The ventilator tubing is disconnected. There's just some kind of leak somewhere. Now we talk about ARDS. A lot of questions on ARDS on the first exam, and I don't know what the final has, but you just need to know in general that ARDS is a complication because of an inflammatory problem, and there is leakage of fluid that goes into the alveoli from the bud space. That is the reason for the crackles that you hear, or the physician will diagnose alveolar infiltration. So that's water in the alveolar space. The common risk factors are any inflammatory complications. So you can see that that pretty much deems just about everything in our critical care information is puts a patient at risk for ARDS. It doesn't always happen, but some people, for whatever reason, do develop ARDS because of their inflammatory problem. And you, the nurse, have to be on the lookout for it. Again, key terms that say to you, hey, this exam patient has ARDS, and that's diffuse injury to the alveolar capillary membrane, refractory hypoxemia, and infiltrates. That is a key thing. Neuromuscular blockade and sedation and analgesia. What's the story with this topic? Well, let's talk about any patient who is very, very sick. And any patient who is very, very sick and needs very aggressive ventilator management, a lot of times the physician does not want the patient to breathe. It's kind of in our mode that if the brain's working, the brain's going to want to breathe. And so if we don't want the patient to breathe because perhaps their breathing is not going to be synchronized with the ventilator, and it causes the patient distress, and it keeps sounding alarms because the patient is fighting the ventilator, that's when they may use neuromuscular blockade, which is a fancy way of saying paralyze the patient. So here's your reasoning of why neuromuscular blockade is used: to improve oxygenation, to provide synchrony. It helps manage high airway pressure. So these are the things or the reasons why neuromuscular blockade is utilized. I liken paralysis or neuromuscular blockade to being similar to be buried alive. Patients can see, hear, and think, but they can't move, they can't speak, they can't communicate, and so it's like they're trapped inside their body. And that's why sedation and analgesia must be maintained. Once a patient is placed on neuromuscular blockade or they're paralyzed chemically, then therefore you, the nurse, have to do that train of four. That train of four is an assessment of how well or how poorly the dose of the paralysis medication is. We want 1 to 2 twitches. That means there is some muscle activity, but not too much and not too little. And there's usually a recipe that is prescribed by the physician that if there's if there's 0 twitches, that means the patient is too paralyzed. You would decrease the neuromuscular blockade. If the patient had 4 twitches, well, then they're not paralyzed enough, and you would increase the medication. So again, you always have to think opposite. If the problem is over-paralyzed, then the fix is decreased drug. If the problem is under-paralyzed, then the fix is increased drug. VAP, ventilator-associated pneumonia. So we know that ventilator-associated pneumonia is, number one, a nosocomial infection, and therefore it is expensive for the hospital, but it's more costly for the patient because the patient has a higher mortality with ventilator-associated pneumonia, and so therefore you, the nurse, have to do measures to prevent ventilator-associated pneumonia from occurring. These are the VAP best practices: hand hygiene, head of bed elevated, teeth and tongue brushing with chlorhexidine twice daily, oral care in general, oral suction as needed and before positioning change. Subglottic suctioning means to suction the secretions that might drip down the back of the throat. Patients can't swallow. And that's why the head of the bed does help with that, but you have to make sure. And then ensure that the respiratory therapist maintains the endotracheal balloon pressure at 20 millimeters of mercury. It can be 15 or minus, it can be plus or minus 5, which really gives you a range of 15 to 25. And then we don't want the respiratory therapist to change the circulator tubing very often because we don't want to interrupt the system and create more risk for infection. VAP best practices, gotta know it. Switching gears to new material, and that's the shock. Quite a bit of exam, the final exam has shock questions on there. I think it's represented fairly heavily. So let's talk about shock in general before we take a break and talk about specific shocks. Shock in general, the very definition of shock, means that there is inadequate or decreased tissue perfusion. Whenever I say perfusion, your head should go to oxygen. In other words, there is not enough oxygen at the cellular level. That is not the same as saying that there's not enough oxygen in the blood. That is not the same. Perfusion, again, we talk about tissue oxygenation. If the cells do not have enough oxygen, then they convert to anaerobic metabolism. The byproduct of anaerobic metabolism is lactic acid. The body produces a lot of acid. It's going to drive the pH down to an acidotic state. And in and of itself, an abnormal pH can cause the cell not to work very well. Anytime there is a prolonged period of abnormal pH, that can cause the cell not to function, and then the cell can die. So let's talk about this force, this appropriate force. So we know that, again, a lack of perfusion at the cellular level does not mean that there's low O2 in the blood. Nope. There's even a special term for it. Hypoxia is low O2 at the cellular level, and the O2 in the blood can be just great. But if there is not a high enough MAP, a MAP is that pushing force. It's this ninja here that kicks the oxygen off that hemoglobin and sends it into the cell. And if the MAP is not at least 65, though Dr. Reed says 70, then that oxygen is just going to hang out with the hemoglobin and it is not going to go into the cell. You must know how to calculate a MAP, and I've got the formula there for you. Don't memorize it. Write it down. Let's look at this. I've told you earlier that truly exam questions are tricky because you're like, well, how bad or how ill is this patient? And the only way, or one of the ways to tell how ill the patient is to look at the assessment characteristics or descriptors. We can see that with any poor perfusion state, these are the signs and symptoms that you can expect to see. I would pause the recording if you don't feel like you know it, and just identify that, okay, if I see this, then I see that this can indicate that my patient is not doing well. I would say to you very clearly that blood pressure can be an indicator, but don't pick it as a first-line answer choice because you know there is compensation. Compensation such as the sympathetic nervous system and the RAS, all kinds of compensation. So it is a tricky sign and symptom to indicate any kind of problem. You got to consider it, but look very carefully if there's a better other option. What about the shock states? Well, I said there's several, 4 different kinds of shock: distributive, hypovolemic, cardiogenic, and obstructive. And what I would do is put a grid, what I call the shock state grid, on your final exam sheet. This tells you about each shock state and what you can expect to see. This takes the thinking out of it in case you get a shock question on the next to the last question when your brain is pretty well fried. So I've got it written out for you. So you can see hypovolemic, cardiogenic, neurogenic shock, even though it is a distributive shock. I listed it separate because it has this one very odd sign and symptom. The heart rate is down as opposed to up as in every other shock state. Distributive shock, warm sepsis, or the warm stage of sepsis. Now a lot of students, and then there's the vital signs there, or what you can expect to see, the grid. Now, a lot of students will email me and say, well, hey, if there's a warm stage, there's a cold stage. What's the cold stage of sepsis? The cold stage of sepsis looks just like cardiogenic shock. This is where your patient is not going to do very well. Vasoconstriction, the volume is high, the heart is not working at all, the heart rate's high. So really the cold stage of sepsis looks just like cardiogenic shock, which is why you're frequently asked about the warm stage of sepsis, because it has its unique characteristic of an increased cardiac output. Again, put your own grid on your exam sheet. If you like mine, you can use mine, figure your own, but put it on your exam sheet. I hope this has been helpful. Please email me if you have any questions.